Good morning. Let me present fascia and low back pain. So if we try to analyze the subcutis, we can see at the top the skin, below we can see the superficial adipose tissue. In the middle of the adipose tissue, we can see the superficial fascia. Then we can see the deep adipose tissue, the deep fascia, and the muscle. So this is just to introduce what is fascia and what is the different type of fascia. In this presentation, we will talk about deep fascia that is definitely more related to mechanical pain, like low back pain. So if we try to dissect the back, we will be able to remove the superficial adipose tissue and see this kind of white pearl color membrane that is what we call superficial fascia. So this is the border of the trapezius. Right here we have the head and the neck. This is the low back area. So you see, it takes a few hours, but if you want, you can really distinguish, isolate this structure that still have some level of fat, but it's of course like different from the adipose tissue. So skin, superficial adipose tissue, superficial fascia. In this picture, we have a cut superficial fascia from the side, isolated from the underlying deep adipose tissue, and we have left the superficial fascia. As you can see, it's like a membrane that is difficult to separate from the fat, but you can do that. Close to the middle line, the superficial fascia is adherent to the supraspinal ligament. So at this level, so right on the top of the supraspinal ligament, this dissection cannot be performed. So look into a CT scan, you can see our superficial fascia. So this is what we have just saw. As you can see, this merge so on the supraspinal ligament, but don't forget the superficial fascia go all around. You can clearly see that the superficial fascia is an element that is present all over the body. And we have to figure out what is the role, what is the importance of this tissue. And we want to also underline that MRI can be a good tool to study this tissue. As you can see in a T1 row, you can see the superficial fascia. In the middle of the superficial adipose tissue, deep adipose tissue. And right here, you can see the thoracolumbar fascia. Thoracolumbar fascia is related to low back pain. Superficial fascia will be never related to chronic mechanical low back pain. So this is important because in T2 or T1, superficial fascia will be always recognizable. The deep sometimes not, because if you don't have fat infiltration, the muscle will be black as the deep fascia. So you will not be able to count to analyze the thickness of this structure. And this will give you problem when it's time to understand it, if the thickness of thoracolumbar fascia or the stiffness of thoracolumbar fascia can be the origin, the source of low back pain. As we know from Langevin, the thickness of this structure is in relation of chronic low back pain. So we have removed the superficial fascia right here. This is the thoracolumbar fascia. This is the gluteus max. This is superficial fascia. This is trapezius. Okay. So as you can see, as we take it off this tissue, it's quite elastic. It's still the superficial fascia is still like an elastic tissue. It will be very important, in particular for autonomic problem, like we have right here, Pacini, Ruffini, corpuscle, Merkel, Mesner, receptor, a lot of autonomic nerve fibers. But of course, it's a structure that have a capacity, like a mechanical low capacity, not as strong as the deep fascia. In fact, we have taken different sample of the superficial fascia. We have tried to make a mechanical stress transversal and longitudinal. And we saw that like a sample like this can hold like 8.5 kilogram transversal and 6 kilogram longitudinal as a mean value. But on the top is way more resistant. We will see that the resistance right here can reach up to 10 kilogram. Why? Because in this area, there is a lot of vessels. And this vessel will increase the strength, the resistance of this tissue. At the opposite, the deep fascia over the trapezius is very thin, very fragile, and so is like a quite particular area. I mean, you will find out that the superficial fascia is even more resistant than the deep fascia. So it's very important to understand what is the physical characteristic. So as I said, superficial fascia from T1 down to L5. I mean, the resistance can go from 10 kilogram down to 3-4 kilogram. As you go down, resistance in longitudinal, it will decrease from 6 down to 1 kilogram. But still a tissue that have like a reputation, again, an importance in our body. So now we can understand also the relation with other structure, like this is superficial fascia, this is the latissimus. You see, at the end of the day, latissimus dorsis is not as much resistance than the superficial fascia. The two structures are quite similar. Latissimus is very wide, but it's very thin. And the muscle fiber by itself are very soft. So at the end of the day, it's true, it is not as strong structure, but it is similar as a mechanical property to muscle as latissimus dorsis. Then let's go down. Let's try to see what happened in the lower level. So right here, you can see the thoracolumbar fascia. This is the superficial fascia that we have removed. There's just still one layer, okay, like a portion of that. Right here is the gluteus max coming down. This is the fascia lata over the gluteus medium, okay? This is the latissimus dorsis. So you can see how many collagen fibers are merged in the thoracolumbar fascia, and how superficial fascia is quite independent from the mechanics of our body. In fact, we move without move the skin, or vice versa. We move the skin, but the underlying structure doesn't move. So moving on with the deep fascia, the trunk, I mean, it results a very important anatomy that has to be studied, because the layer, the level of the muscle can be sometimes tricky. Which muscle is above the other? I mean, is the trapezius above the deltoid or vice versa? Okay. How is the relation between serratus posterior superior and other structure? So it's important to understand the fascial layer. And we find out that the deep fascia in the trunk is similar for some reason to the limbs. We know that the fascia lata, crural fascia have 3-layer collagen fiber. One attached close to the other that they can glide independently. Well, in the trunk, we still have 3 layers. But each layer surround are completely adherent to the muscles that are within these two. So for instance, we have a layer of fascia that split and surround pectoral major, latissimus dorsis, trapezius, deltoid, and gluteus max. So this superficial layer is the last one that developed during the evolution. It works for more complex motion, rotation. We have a medial layer that includes serratus posterior, inferior, posterior superior, serratus anterior. And as we can understand, it works for other motion. And a deep layer, the more archaic, that is related to spina, erector spina, intercostal. So what is the advantage of this fascia in the trunk? That we call epimesial fascia, because it's like an epimesium, like it's completely adherent to the muscle. But what is the major difference? That when muscle stops, the 2 layers come together, but they keep going, and then the splits run another muscle, and then come together, and then splits run another muscle. So the deep fascia in the trunk has the amazing capacity to transmit force between neighbor muscle that they have a motor unit that co-work in synergy. So for this reason, the anatomy of fascia is very important, because you can see the continuity, the relationship, the low transmission that we have in the body. Remember, the epimesial fascia in the trunk is like an epimesium, so it's extremely adherent to the muscle. It goes between the muscle fiber and perimysium, and then can get onto the endomysium. So it's really inseparable if you don't start to cut one after the other all the perimysium septa. So it's like a sandwich, one layer on one side, one layer on the other side, and perimysium goes side to side. So we can see another example of epimesial fascia. You see, it's not thick at all. It's really thin. You see here it was the image, so you see clearly the muscle below, but you can, you can clearly see how is the muscle below. So the layer is like a 0.1 millimeter, 0.5 millimeter, okay? But again, in the trunk, you cannot separate the function of the fascia from the function of the muscle, because you see this white layer right here. These are all perimysium. So it means from one layer of epimysial fascia, you go deep with this perimysium that separates the muscle bundle. And on the other side, we have another epimysial fascia. So you generate this sandwich that allows the independency of the different motor units localized in the same muscle. And this can be critical because with a large origin, as well as a large insertion, you will see later on, latissimo merge with a strong connection with the posterior region of the brachial fascia. And with a lot of motor units, you are able to perform many more motion, stressing less the joint. Because you are able to modulate the tension from the region to the insertion. But don't forget that this fiber, collagen fiber, they can even cross the middle line. So we are in the pubic region. You see the pubic right here, the funiculus spermaticus. So you see collagen fiber from the rectus abdominis sheath that cross the middle line. Other collagen fiber that cross the middle line. So as you can see, this collagen fiber, this layer, they should be able to glide independently to perform motion. So sometimes like a C-section can be a major problem because you start to generate an adhesion between different layers. And not in the short term, or the middle or long term, female can have opposite symptoms like low back pain, upper back pain, due to the scar in the antagonist structure. So there are a lot of areas like the thoracolumbar fascia, like the retroabdominal sheath that we call like a retinacula. You could know very well the retinacula of the wrist. You know very well the retinacula of the ankle. But in reality, in our body, we have a lot of retinacula, like in the abdominal region. So the retroabdominal sheath, you see collagen fiber going in this direction, and then we have collagen fiber vertical. So what it means? It means that right here we have a conversion of different load in different directions that will facilitate specific motion. We have a retinacula in the back, like in the front of the abdominal sheath. So this area we will not call epimysial fascia because you see it's thicker, more white. You can see the collagen fiber. So this is typical aponeurotic fascia, still deep, and it's a deep aponeurotic fascia versus a superficial epimysial fascia, okay? The superficial layer of the deep fascia, epimysial. So deep epimysial fascia, deep aponeurotic fascia. Of course, there will be another layer deeper with this one for the serratus posterior anterior, another layer even deeper for the intercostalis. So to summarize, in the trunk, the layer fascia are thinner, but strongly adherent to the underlying muscle. So that means that you cannot really separate the function of the muscle from the function of the fascia. So whenever you palpate a patient, you are palpate both simultaneously. And whenever you do manual therapy, you cannot distinguish if you are working fascia or muscle. You are working both. And this is what has to be done. So going more specific in the thoracolumbar fascia, of course, is like a retinacula. You see collagen fiber in one direction, two direction, okay? There will be a third direction below. So, of course, transmitted force from the latissimus, transversus, oblique, they will converge, it will cross the middle line. It will merge in the contralateral glute, for instance. So the thoracolumbar fascia, is a complex structure. It's permitting low transmission between the two hemisomal, between the inferior limbs, the upper limbs. And again, all the direction of each single collagen fiber are there for a reason. So there is a reason why we have this band of collagen fiber that go into the gluteus max collagen fiber. So this portion of fascia merge with the fascia of the gluteus max. This can explain why sometimes you have low back pain that is spreading down to the glutes, and then through the fascia lata can spreading down up to the leg. This will explain the majority of this unspecific sciatic pain. That is just an irritation of the freehand nerves along specific line of force in the fascia, because the fascia is really well innervated, so it can generate afferents. If the threshold, like if the receptor that are implanted in the fascia get irritated, stimulated mechanically by stiff fascia, you decrease the threshold activation, so you have a bombardment from there. Again, remember that in any case, the deep fascia should be able to glide independently, should be able one layer to glide over the other, But what happened? Sometimes this does not occur. And so you have become stiff the structure, pull in one direction, you stress also the other direction. And so you can irritate the mechanoreceptor that should not be activated. So you can have a bombardment from there. So like a nociception. Because even if it looks like a multiple layer tissue, in reality, like in a regular mesh, in reality are different layer one over the other. It seems like an irregular mesh, but in reality is a multiple layer. Each layer has to be independent to glide over the other. So when you check with the histological point of view, you can see like one layer, two layer, and a three layer. Goes better right here. One layer, this is the image. This is one layer collagen fiber, two layer collagen fiber, and three layer collagen fiber. So you have like the superficial, the intermediate, and a deep one. Superficial layer is formed by parallel, intermediate formed by clock packet collagen bundle, and then the third one. Each layer is separated by loose connective tissue to allow an independence of the glide of each single layer. So the loose connective tissue is mostly made by adipose cell, glycosaminoglycans, and hyaluronan. So here we see an example. This is a parotic fascia. Then we have loose connective tissue. You have a second layer of deep fascia, loose connective tissue, another layer, and then loose connective tissue, adipose cell, the other structure. So you can clearly see how each layer are independent. But what is the key element that permits the independence of each single layer? The hyaluronan. Hyaluronan are multiple cells in cluster, so one attached to the other. But instead to produce like a collagen fiber, they produce hyaluronan. So hyaluronan is the chief component of the extracellular matrix of the loose connective tissue, because it's able to produce a lubricant, you know. And these cells that we have called fasciocytes are related to this specific function. And so we are analyzing now if the fasciocyte maybe can get a problem, then it can produce less hyaluronan, or the incorrect one, and so generate an extracellular matrix that is more viscous. So this is our hypothesis. So we have tried to take 100 samples of the lumbar fascia, reconstruct with the ultrasound, and then with a specific software. What we were able to see, a portion of the first layer, or the second layer, and the third layer. Between each single layer, you see like the blue. The blue is the loose connective tissue that allow the independent gliding of each single layer. What is curious that the innervation are different. Not each single layer have the same innervation. So you see muscle, inner layer, middle layer, outer layer. The outer layer showed a particular dense innervation with sensory fiber, while the middle layer, the inner layer, did not. What it means? It means that basically the middle layer is more low transmission, probably. The inner layer still work for like an independence from the muscle. And the outer layer is what exactly is able to categorize, analyze what kind of afferents can come from there, and then generate feedback for make it happen. So remember that inside the deep fascia, epimedial fascia, we have nerves, many nerves that we have saw before. The nerves are recognizable with a histological sample because with S under it, you can understand like what is the free nerve endings. You can see a corpuscle, you can see a free nerve endings. So all these structure, basically they are activated by stretching of the connective tissue. And then this structure will generate like a kind of afference. And this afference will generate the proper afference in the perception of the body in the space that we call proprioception. But going deep, I mean, you will see that these cells that we call fasciocytes are really present all over the surface of the body, not just in the our study. So whenever there is an interface, hyaluronic will produce hyaluronic acid or hyaluron. So as you can see from here, this stratus posterior superior, stratus posterior inferior. Over here, there was like a lack of gliding, and then you make a surgery, and maybe you can add some lubricant to increase, to stimulate the biological condition. Here you can see the lumbar fascia above and below. You can clearly see the serratus fascia. So the fascia connected the two types of serratus. What is curious is that normally this alteration will occur soon. In reality, sometime what happened that if you have a lack of gliding, maybe the patient will start to feel problem at the top, or the patient will start to feel problem at the bottom. But in reality, there is a continuity. So working on the top can affect the bottom and vice versa. So here we have other imaging of the stratus posterior inferior. Okay, it's very tiny, emerge in the fascia. So origin from the rectal spine, but merge into the fascia. So it's really a tensor of the fascia. Go ahead, we can remove the latissimus and we can get to the rectal spine. The rectal spine, as you can see, are on side of the spinal process, are covered by the like a paraspinal sheath. There is like a superficial area, very aponeurotic, that will transmit a lot of force, but there is loose connective tissue between this surface and the like a rectal spine sheath. So when you open up between the two, between this structure and this, there's loose connective tissue. So this is basically where the rectal spine originates. But of course, this can transmit the force up and down, and that has to be independent by the container. And the container is, by the way, the surface of the rectal spine. In fact, in the past, they were saying that closing and making more resistant the region around the rectal spine will increase the strength of this muscle. So if we clean up properly in the back, we see that as we go back, more difficult is to separate the different layers, because when you go in the superficial, you go like over the sacrum, what happened? Right there, there is like a fusion of all the collagen fibers. So right here, there is a convergence, a fixation of all the collagen fiber. So if there's an incorrect pulling from one area to the other, this is the area where patient will perceive most the pain, because this is there where the H angulae will reach this sacrum, okay, or the surrounding area. It will merge there, it will not separate. So that is why, in our opinion, this is a very common area of symptom, because all the collagen fiber reach the periosteum at this level. Here's another picture to show you how collagen fiber converge and reach this area. Okay. It is nothing new, because it was presented a long time ago by Willing, that he said that the fascia go from latissimus to the lumbar fascia to gluteus maximus contralateral and to the rectal spine, or rectal spine, to the lateral portion of the IT band. Honestly, we don't think that this is like the perfect and isolated solution of all the anatomy, because there's other component that can help for this transmission. But this can help you to understand when you run how this structure works together, how the tension is generated can be transmitted down to the leg. So it was a good article to introduce these concepts, introduce like a discontinuity. And here you can see very well, you can see the rectus spine, right here, they merge with interlumbar fascia, connective tissue, and then in the gluteus maximus, they have an epimysial fascia. The upper surface, the inner surface, they merge, they generate one layer of the fascia lata. Here we have open up, and you can see a little bit like the thickness of the structure. And here you can see how the tensor fascia lata merge completely in the fascia lata. So these structures are really strong. You can transmit a lot of the force down to the leg. So we have tried to give our proposal how we define the collagen fiber and how we identify from where they are coming, from where they are going. So like the deepest fiber, the red one, are related to the more like a posterior part of the gluteus max, more of the rectus spine, and going the more posterior part of the cuff in time. So these are the deep fiber, the deep part that will work a lot for what we call sagittal plane. But we have also to describe another continuity, the one that was already present in literature. So latissimus dorsi, turnover fascia, gluteus max, IT band. So this is more superficial because the gluteus max was not developed soon as a muscle, but clearly explain how transmission can go to trial for this continuity, and how you can explain a lot of low back and sciatic pain that they don't match so well with this herniation, because a lot of times this herniation is just one of the manifestations of the problem, but not the original problem. So our proposal is this. So we believe that if we want to classify properly the anatomy of fascia, we have a anterior layer and a posterior layer. The anterior one have the oblique internal muscle, the transverse abdominal muscle, and for the latissimus dorsi, for the posterior layer, we have latissimus dorsi, oblique external muscle that will generate the posterior part. Few of them, the azure, light azure, for instance, are a little bit questionable, and so we are still working to understand which one will be more, appropriated. But what is important to understand that there is a perfect continuity. So sometimes tension is perceived in the back, maybe originating from the front, or vice versa. So, for our opinion, in order to give like a core stability to the vertebra, of course, we have to activate, use the best rectal spine, but don't get too much rigid iliopsoas, okay, or quadrilateral, because these have still a leverage to go against the other one. But this fascia anatomy will help us to understand that even the abdominis, the tension of the muscle, can affect a lot the lower pain, and vice versa. So this is just to explain how the body is connected and how work with a logic. So antagonist of the symptom can help you to figure out what is wrong and how you can treat the patient. So because the turnover fascia is really complex anatomy with a lot of collagen fiber coming from a lot of structure, gluteus maximus, latissimus dorsi, transversus, oblique internum, oblique externum, rectus spine, serratus fascia. When it's time to analyze, you have to take into consideration that each of them can be a source of tension. Okay, and we have proved with a particular study at the level of the hip how is important the innervation of fascia, how it has to be taken into consideration. And it shows up that the most innervated, like one of the tissues that are more innervated, are, by the way, the superficial fascia with a lot of autonomic fiber. Most of the fascia is not doing so well, so bad, because even if it's small and the number diameter, like the diameter of this capillary are very high, they tell you that there's a lot of motor units correlated, but not sensory. So checking just the diameter that are more related to the sensory we see that we have an increase, drop, an increase, and now we start to get a plateau. So probably this can be important to explain that the capsule and tendon maybe are not really the origin of the symptom. You see, the number of receptors per centimeter square are very low. The diameter is quite high, but diameter means like a motor fiber. So our deep fascia is definitely more related to painful sensation that come from people believe capsule of tendon. So we did like a few pictures of the free nerve endings in the low back area of the rafts. You can see with like a multiple layer analysis, you can clearly see like a polyhedric distribution of these free nerve endings that can permit to the body to perceive the motion, because as you deformate this polyhedric, in the way you deform this polyhedric, you can explain what's going to happen. And this was a very good study from Schindler. They say, look, let's try to inject saline in the subcutis, in the fascia, in the muscle. Let's check which one generates more pain. And the patient described the injection of saline in the fascia, the one that have more symptom, more adhesion in a wide area. So that means that this subject or every subject have a lumbar fascia really well innervated that can be a painful generator. Again, in the questionnaire, we're asking how you feel the subcutis, okay, when you inject the saline. And the patient will refer like a stinging, heavy, burning, exhaustion. That it could be like a pathognomonic specific for push over, area that are well innervated from a fascia point of view. So what is the advantage? That this mesh can be pulled in one direction, the other direction. So you will still activate the free nerve endings, but with a spatial disposition, spatial like a direction. So this way that you activate this mesh will generate afferents that will be re-elaborated by the autonomic, by the central nervous system. And from that, you will be able to interpret it, understand from which direction we were moving the arm. So for this reason, the deep fascia is very important. It's innervate nerve for continuity, gluteus max, latissimus, transversus, oblique internal, oblique external, erector spine, stratus fascia. So this is like a measure of the nerves. You will find out in all this kind of fascia. So for this reason, whenever the patient starts to have low back pain, you have to take in consideration the quality of this tissue. You have to try to find out if there's some area that doesn't glide properly, that can be the origin of the problem. Even if the symptom is far away, we just understood that the rigidity can be in one place, but the symptom can be when this tension, the incorrect tension will discharge over the entasis, like the joint or wherever it was. So very important to take into consideration the fascia as a source of pain. So thanks a lot for your attention, and I hope that you get some information about the role of fascia. Thank you.